Assalamualaikum and good day to doctor and friends. We from Team 4B is going to present our case, which is the 55-year-old Malayan female diagnosed with type 2 diabetes mellitus, hypertension and hypercholesterolemia. So basically this is patient information. She is overweight with no drug allergy. Family history, both parents have diabetes and hypertension. Social history, the patient admitted to consume caffeine. She has type 2 DM for 10 years, hypertension for 10 years, and hypercholesterolemia for 4 years. She is on 4 medication, and she also takes supplement which is coconut oil, olive oil, and fish oil. In terms of adherence level, she has poor adherence to simvastatin.
Clinical condition: first one, hypertension. Goal of treatment is to target blood pressure level of less than 130/80 and to prevent cardiovascular complication. Current medication: irbesartan 300 mg and hydrochlorothiazide 12.5 mg OD. Justification on irbesartan. Angiotensin receptor blocker ARB is a first-line antihypertensive agent in diabetic patients. It has cardiovascular protective effects and effective in preventing progression of diabetic kidney disease. The dose is appropriate. Irbesartan 300 mg per day exerts a significant renal protective effect in hypertensive type 2 diabetic patients. Justification on hydrochlorothiazide. Thiazide diuretic can be added when monotherapy is inadequate. It is the preferred second-line therapy for most hypertensive patients with diabetes. Thiazide provides synergistic antihypertensive effect when combined with ARB. Dose of thiazide is appropriate. Higher dose may cause electrolyte and metabolic adverse effects, so lowest dose received by patient may prevent this from happening.
For clinical condition of type 2 diabetes mellitus, goal of treatment for this patient is achievement of appropriate glycemic levels. First, fasting or preprandial blood glucose of 4.4 until 7.0 millimole per liter, and postprandial blood glucose of 4.4 until 8.5 millimole per liter, and lastly, A1C level of below than 6.5%. As for the current medication list, patient have been taking metformin hydrochloride 400 mg twice daily for the past 10 years. For the justification on medication, as the first-line therapy, metformin is the preferred choice, and other oral antidiabetic agents are acceptable. Metformin lowers the blood glucose, especially fasting blood glucose, by decreasing the hepatic glucose production and also does not stimulate insulin secretion. Thus, on its own, it is usually not recommended with hypoglycemia. Metformin also reduces A1C level by about 1.5%, and one of the benefits of metformin is either weight stability or mild weight loss, since patient is overweight. As for the dose is appropriate according to PPUK and formulary, initially 500 mg or 850 mg 2 times daily or 3 times daily.
For clinical condition of hypercholesterolemia, the goal of treatment is to achieve a target LDL-C level of less than 2.6 millimole per liter. The medication the patient was on for the past 4 years is simvastatin 20 mg OD. The justification on medication is that statins has always been the drug of choice in reducing LDL-C level due to its ability in inhibiting synthesis of cholesterol. In patients with hypertension, statin therapy effectively decreases CV morbidity and mortality. In persons of more than 40 years with type 2 diabetes mellitus with no overt CVD, statin therapy have efficaciously reduced risk for CV events, irrespective of the baseline LDL-C. Thus, the choice of simvastatin is appropriate. However, simvastatin dose of 10 mg is more appropriate than 20 mg. According to MIMS, since patient is also taking a fibrate, which is ciprofibrate, the maximum dose of simvastatin that the patient can take daily is 10 mg. This may be due to simvastatin and ciprofibrate having major interaction that may increase risk of myopathy. Thus, it is recommended that simvastatin 20 mg OD should be decreased to simvastatin 10 mg OD. For hypercholesterolemia condition, the patient was also on ciprofibrate 100 mg OD, and the goal of treatment is to achieve a LDL-C level of less than 2.6 millimole per liter, HDL-C level of more than 1.2 millimole per liter, and DG levels of less than 1.7 millimole per liter. The justification of medication is that monotherapy with only statins or only fibrates does not always achieve lipid goals in dyslipidemic patients. Furthermore, Even in patients who do achieve lipid goals with monotherapy, there often remains a high residual risk of CV events, warranting even further therapy. Thus, due to the distinct mechanisms of action of statins, which is primarily lowering LDL-C level, and fibrates, which reduce TG levels, improve LDL particle size and number, and increase HDL-C concentrations, this provides a rationale for combined use in the treatment of patients with dyslipidemia and high residual cardiovascular risk persisting after single therapy. Ciprofibrate dose of 100 mg is appropriate in this patient, since overdosage may lead to rhabdomyolysis.
For irbesartan and hydrochlorothiazide drug combination, a blood pressure level of below 130/80 mmHg should be targeted as the monitoring parameter for efficacy. Renal function parameters like serum and electrolytes should be monitored as this drug combination may cause alterations in renal function in susceptible patient and hypo or hyperkalemia. Hydrochlorothiazide might increase uric acid levels, so this should be monitored too. Common side effects include musculoskeletal pain, dizziness and postural hypertension, headache and fatigue. HbA1c, fasting and random blood glucose levels should be monitored to assess the efficacy of metformin. Renal function and hematologic parameters should be assessed at baseline and annually, as impaired kidney function increases the risk of lactic acidosis, and blood coagulation disorder and hemolytic anemia has been reported with the use of metformin. Vitamin B12 serum concentration should be monitored every 2 to 3 years, as vitamin B12 deficiency might also occur. Common gastrointestinal side effects are usually transient and resolve with continued treatment.
I'm Nur Azrina and I'll explain about monitoring for dyslipidemia and drug-related problem. For monitoring of efficacy for simvastatin 20 mg, the lipid profile should be monitored where the LDL level should be less than 2.6 mol per liter. For ciprofibrate, for the lipid profile, the LDL should be less than 2.6 mol per liter, the HDL should be more than 1.2 mol per liter, and triglyceride level should be less than 1.7 mol per liter. For monitoring of safety, the liver function should be monitored, the sign and symptom of myopathy and rhabdomyolysis should be monitored, and for ciprofibrate, the sign and symptom of GI side effects should be monitored. For drug-related problem, firstly, the patient has poor adherence to simvastatin, where the problem should be managed by educate the patient about the importance of adherence to medication and ask the patient if the patient experiencing any unwanted side effects after taking the medication. Lastly, the dose of simvastatin is inappropriate. Based on means, when a patient taking fibrates together with statin, the maximum dose of statin should be 10 mg. Thus, the dose of simvastatin should be reduced to 10 mg.
Moving on to pharmacist intervention, poor statin adherence can be improved by promoting positive medication taking behavior in the patient. This will be done by explaining to the patient how each medication works, so that the patient understands taking this medication will control her condition. Next, dietary advice is also important to control the condition, as each consumption will lead to reduction or worsening of the condition. Next, pharmacists should highlight the importance of lifestyle advice. Aerobic exercise help to improve insulin sensitivity, promoting weight loss, and also lower the blood pressure. Next, assessing safety and effectiveness of medications during each follow-up is also part of pharmacist intervention. This can be done by pharmacists asking the patient, do she experience any side effects or adverse drug reaction while taking the medication. As for effectiveness of medication, this can be assessed by taking suitable or necessary lab parameters. Patient role in self-monitoring is also part of pharmacist intervention, in which pharmacists will explain or list down target range to be achieved by the patient, and the patient, if they have their own electronic blood pressure machine or glucose reading machine, they can take the reading every single day and see whether it matches the target range. Besides that, pharmacist intervention includes supporting consistent consumption of fish oil and olive supplementation, as they are proven to help in managing the condition of the patient in this case. Last but not least, pharmacist intervention include addressing common side effects of medication and how and what patient can do to ease the sign and symptoms. For example, metformin is associated with risk of hypoglycemia, so patient is advised to take meals or carbohydrate-rich or drink fruit juice immediately when they experience defining symptoms. As for antihypertensive agent, since it causes dizziness, patient is advised to not drive or operate machinery. Same goes when she experienced that while taking cyclofibrate and simvastatin.